Assalamu alaikum. Today we have learned the chapter anti-cancer drugs, number one part, which is cytotoxic agents. And we have learned already that the anti-cancer drugs are grouped into two major classes, that is the cytotoxic agents and the non-cytotoxic agents. So here in this chapter, we have some and cytotoxic anti-cancer drugs which basically act on cancer cells to cause their death. These cytotoxic drugs can be subdivided into eight major groups. Further major groups, that is the alkylating agents, the platinum compounds, the antimetabolites, the hypomethylating agents, the anti-tumor antibiotics, mitotic inhibitors, topoisomerase inhibitors, and other miscellaneous cytotoxic drugs. Now, first of all, before starting the groups and the individual drugs of anti-cancer agents, we have to understand the mechanism of cytotoxic activity and the cell cycle phase specificity. So, the principal mechanism by which cytotoxic anti-cancer drugs act, basically they disrupt process related to the DNA synthesis and its precursors. The precursors, nucleotide and the protein which are involved in the synthesis of RNA and then DNA. Basically, these their interruption, their de-escalation or their deformation, and the disruption of the synthesis of DNA. Basically, these cytotoxic agents act on that activity. Um, in addition, some agents, for example, vinblastine and vincristine, act specifically to block mitosis. And basically, these are mitotic spindle inhibitors, and they act on the M phase of the cell cycle. Um, and the cyto and also the cytotoxic drug disrupt processes carried out exclusively by cells that are undergoing replication. These drugs are most toxic to tissues that have a high growth fraction, that is the high proportion of proliferating cells. So uh, we can understand by reviewing this mechanism, that during the cell growth, during the mitotic phase, during the proliferation of cells, the cytotoxic agents act proactively, while during the resting phase, that is the G naught phase, the cytotoxic agents might be in the system but not actively target the cells, the cancer or the normal, whichever it is, but it needs to be the proliferation of cells. Now come towards the cell cycle phase specificity. This cell cycle is the sequence of event that a cell goes through from one mitotic division to the next division. Some anti-cancer agent known as cell cycle phase specific drugs. This is the very important that you must know that which are the drugs which are phase specific and which are the drugs which are phase non-specific, first of all. And the phase specific, you must know which phase is actively against with it. So you know the G1 phase specific drugs, you must know the S phase specific drugs, and you must know the G2 and M phase specific. So, in cytotoxic anti-cancer drugs, are most of the cytotoxic anti-cancer drugs are phase specific, and remaining of them are non-specific. The phase specific, you must know the G naught phase is the phase in which the anti-cancer drugs, their toxicity will not be harmful to the cells. So as it is mentioned earlier, that it must show the proliferation, it must show the cell division or cell growth, and at that moment the anti-cancer drugs are highly active and shows the anti-cancer cytotoxic activity. One more point here is to be discussed in cell cycle phase specific drugs, that uh, I show you in next page, that is That is the point. The dosing schedule is so critical to therapeutic responses. The phase specific drugs are also known as schedule dependent drugs. So their specificity also uh, shows the schedule, also shows the dosing schedule. So these drugs are also known as schedule dependent drugs. Now come towards the table 102.1, in which we have seen the classification of cytotoxic drugs in a brief view, with their brand name, their phase specificity, their route of administration, and their low dose limiting toxicity. Most of the drugs, anti-cancer drug, have the bone marrow suppression as an adverse effect, and the others, which is very common other than the bone marrow suppression, is the GI disturbances. But in this chart you may see the uh, specific dose limiting toxicity related to the drug or the class of drug. So we have eight groups or eight classes of cytotoxic cancer drugs, which are classified as alkylating agent. And alkylating agent is firstly divided into the subclasses, that is the nitrogen mustard, that is the nitrosurias, and the others. In nitrogen mustard we can see the bendamustine, the chlorambucil, the cyclophosphamide, isophosphamide, mechlorethamine, and melphalan, while the nitrosurias consist of carmustine, lumustine, and streptozocin, and other drugs included the bosulfan and temozolomide. The nitrosurias are the first investigational drugs, are the first research products which act against a cancer activity, and not only the experimental basis, it then approved by FDA for anti-cancer activity, and also nowadays it is also used as anti-cancer agent and um, considered in the alkylating agent. So, other than alkylating agent, we have another group, that is the platinum compound, in which the platin is the suffix of all members of the platinum compounds, namely carboplatin, cisplatin, and oxaliplatin. And both these groups of that is the alkylating agent and platinum compound are phase non-specific, as you have seen in the table. Most of the drugs are IV, but chlorambucil and lumustine, temozolomide given as peroral, while the both routes, that is peroral and IV, is used for cyclophosphamide and melphalan and busulfan. And another route of drug which is very particular for mechlorethamine is IV, IC, that is the IV is intravenous, IC is intracranial, and IP is intrapleural, that is in the pleural cavity, which is related with the lungs. And there is very important and specific and very important route of administration, that is CNS implant, which is related to carmustine. CNS implant, it is the transdermal patch, and it is implanted in the brain, as it has a very good um, um, lipophilic nature, and due to this nature it crosses the blood brain barrier. The dose limiting toxicity you can see here in the table, that is in alkylating agent, the infusion reactions related to bendamustine, other than bone marrow suppression, will be the dose limiting toxicity, while in case of ifosfamide, the hemorrhagic cystitis is also related as an adverse effect. In streptozocin, there is a nephrotoxicity is high as compared to bone marrow suppression, while in case of busulfan, the pulmonary fibrosis also observed, and in case of platinum compounds, that is cisplatin, has nephrotoxicity, and oxaliplatin, the peripheral neuropathy, while the rest remain the same, that is the bone marrow suppression is common in all the anti-cancer cytotoxic drugs. Come towards the antimetabolites. You can see the three major groups included in antimetabolites, and these antimetabolites are considered as folic acid analog, pyrimidine analog, and purine analog. And these metabolites are very important and essential proteins which involved in the RNA and then DNA synthesis. And if their analog are provided synthetically um, uh, by the outside, and they competitively inhibit the original folic acid, pyrimidine, and purine bases, and inhibit their activity, and then show with the DNA synthesis and involve in the disruption of the DNA synthesis or RNA synthesis, then it may stop it, not only stop the mitotic process but also causes or lead to the cell death, which is very important in the proliferation during the cancer cell growth. So folic acid analog include methotrexate, the uh, pemetrexate, and pralatrexate, while pyrimidine and analog include capecitabine, citrabine, fluoxuridine, fluorouracil, and gemcitabine. In purine analog, it is cladribine, clofarabine, fludarabine, mercaptopurine, nilarabine, pentostatin, thioguanine. You may see these drugs, that is antimetabolites, are basically the S phase is specific, and in pyrimidine analog you may also see that is not only S phase specific, but they can kill dividing cells only. It is mentioned here in front of capecitabine and floxuridine and fluorouracil and cladribine. While most of the drugs have the route of administration is IV. In case of methotrexate, it is available in IV, IM, peroral, and IT. IT is intrathecal. Capecitabine available only in peroral form. Mercaptopurine is also available in peroral form, while in case of citrabine, it is available in IV form, the subcutaneous form, and IT, again intrathecal, and floxuridine is intraarterial, while thioguanine is available in both peroral and IV. Again, the dose limiting toxicity is bone marrow suppression, but some of the drugs have more than bone marrow suppression. That is, the methotrexate is associated with mucositis, that is the inflammation of mouth cavity. And again, it is also observed in pralatrexate. In capecitabine, not only bone marrow suppression but diarrhea and hand and foot syndrome, in which the numbness and neuronal activity of head and foot observed by giving capecitabine. In case of floxuridine, that is oral and GI ulceration, not only in floxuridine but also in fluorouracil, in addition with bone marrow suppression. And there is another drug which shows another dose limiting toxicity, that is the neurotoxicity in nelarabine. So this is the overview of the antimetabolites which we considered in next lecture, inshallah. Now come towards another class of drug, that is hypomethylating agent. Hypomethylating agent include two drugs, that is azacitidine and decitabine, and these are also as phase specific, and the route of administration is for acetidine is subcutaneous, and the dose limiting toxicity is the same as that of the previous one. Now the another class of drug is anti-tumor antibiotics. These anti-tumor antibiotics include anthracyclines and non-anthracyclines. Anthracyclines basically due to the chemical structure, that is they have an anthracycline group in their chemical structure, and non-anthracycline, that is they have a not in the closed group but they have the same activity, that is anti-tumor antibiotics. So structural dissimilarity are classified into two groups, while most of the drugs have typical or similar reactions, that is the anti-cancer agent. And one more point which should be added here, that these antibiotics are not used to treat the infection but only the tumor activity, that is the cancer cells, to destroy the cancer cells and not the infection purpose. So anthracyclines include doxorubicin and daunorubicin. These are the most important and most primary antibiotics, anti-tumor agent. Doxorubicin and daunorubicin both are available in two forms, that is the conventional form and liposomal forms. Beside this, epirubicin, idrabicin, valrubicin, and metozentron are available as antitumor antibiotics. Most of the drugs are phase non-specific and have the route of administration is IV. While in case of valrubicin, you may see here that is it is G2 phase specific and it is intravesical. Oh, मैं पढ़े जा रही हूँ. Yes. Now come towards the valrubicin. Valrubicin is G2 phase specific and the route of administration is intravesical. And beside this, in non-anthracycline, the bleomycin is G2 phase specific and it has other route of administration, that is IV, IM, subcutaneous, and intrapleural. Now come towards the dose limiting toxicity. The anti-tumor antibiotics not only suppresses the bone marrow but also involved in cardiotoxicity. All the drugs are involved in cardiotoxicity, which is very lethal to the patient. So the drug dosing is should be very calculated, and the monitoring is very important during the infusion of these anti-tumor antibiotics. In case of elribicin, there is another dose-limiting toxicity which is very much different with other anti-tumor antibiotics, that is dysuria, inadequately controlled by phenazopyridine, hematuria lasting more than 2 days. And in case of non-anthracyclines, the pneumonitis and pulmonary fibrosis also observed in the case of bleomycin, while mucositis is related with dactynomycin other than bone marrow suppression. Come towards the mitotic inhibitors. We have uh, three groups in mitotic inhibitors, which is included the plant alkaloid, namely as vinca alkaloid, which is extracted from the vinca plants, vinca rosa, and it included the vinblastine, vincrestine. Vincristine is available in liposomal and conventional form both, and vinrolbin. These are M phase specific. The route of administration is IV, and not only bone marrow suppression, it is also involved in peripheral neuropathy. While the other group is taxane, which included cabazitaxel, doxotaxel, and paclitaxel. And these are G2 and M phase both specific, and the route of administration is IV, and the dose limiting toxicity is common, which is bone marrow suppression. And other drugs include the eribulin, astramastine, and ixabipilone, and the route of administration is per oral in case of astramastine, and this is M-phase specific, while the other two are G2 and M-phase both specific and IV route of administration. Other than bone marrow suppression, they are involved in peripheral neuropathy, eribulin, while estramastine has nausea and vomiting, severe kind of nausea and vomiting, while ixabipilone is bone has a bone marrow suppression while neurotoxicity. Come towards other cytotoxic anti-cancer drugs, which is continued in another page, and it is topoisomerase inhibitor. And we have known the topoisomerase is the enzyme which is involved in mitotic phase, in which the mitotic spindle have a protein tubulin, in which is involved in the division of the cells. So etoposide, irinotecan, teniposide, and topotecan are the drugs which are classified into topoisomerase inhibitor. These are S and G2 phase specific. and these are available in IV form, except etoposide, which is also available in per oral. And the dose limiting toxicity again is bone marrow suppression, while in irinotecan there is late diarrhea also observed. The miscellaneous agent include altratamine, asparaginase, dacarbazine, hydroxyurea, metotane, pegasparagase and procarbazine. They are specificity in case of altratamine are is unknown. It is available in per oral. Bone marrow suppression is the dose limiting toxicity, while in case of asparaginase it is G1 phase specific, available in IV and IM route, and there is no specific dose limiting toxicity, while the other adversities, that is diarrhea or GI upset, are observed. Dicarbazine is phase non-specific, available in IV form. Hydroxyurea is as phase specific, available in per oral form. Both have the dose-limiting toxicity of bone marrow suppression, while is metotane is phase non-specific. Pegasparagase is G1 phase specific, available in IVI and IM, and procarbazine is phase non-specific, and it is also as similar as metotane, available in per oral form. While in case of dose-limiting toxicity, the metotane has CNS depression, and pegaspargase has known. Not observed or not specified, but the most common bone marrow suppression is related with other drugs as shown as previous. So come towards the alkylating agent without wasting our time. We are now considered the alkylating agent, the group of the anti-cancer cytotoxic drugs, which is highly reactive compound that can transfer an alkyl group to various cell constituents. This transfer may proceed to the primarily result in the cell kill because the alkylation of DNA. Because the alkylating agent interact with DNA by forming a covalent bond with a specific nitrogen atom in especially in guanine. So alkylating agent have two reactive sites. The others have only one. Alkylating agent because of two reactive site, also known as bifunctional agent, and they are able to bind DNA in two places to form cross linkages. These bridges may be formed within a single DNA strand or between parallel DNA strands. So the production of this interstrand cross linkages by nitrogen mustard, the alkylating agent, which has only one reactive site, is known as monofunctional agent, while which have two reactive sites are known as bifunctional agent. Because the alkylation reaction can take place at any time during the cell cycle, the alkylating agent are considered as cell cycle phase non-specific. This is the most important thing which we have to learn. That is, these cell specificity are not determined because these alkylation can be done at any time during the cell cycle. So most of the drugs are more toxic to dividing cells because alkylation of DNA produces the most detrimental effect when the cell attempt to replicate DNA, and they are able to repair damage to DNA before it can affect cell function. The resistance is observed because development of resistance to alkylating agent is common because increased production of enzyme that repair DNA, number one, and it also result from decreased uptake of alkylating agent and from increased production of nucleophile, that is the compound that act as decoy target for alkylation. The toxicity included as alkylating agents are bone marrow suppression, and they may also injure the cells of hair follicles, the GI mucosa, and germinal epithelium. Blood dyscrasis caused by bone marrow suppression, the neutropenia, the thrombocytopenia, and anemia. You are very well know about these terminologies. That is the less number, less count of leukocytes and thrombocytes and hematocytes. And these are the causes of neutropenia, thrombocytopenia, and anemia. And nausea and vomiting are very common in cytotoxic anti-cancer drugs, so it is also associated with alkylating agent. Most of the drugs are vesicants, and it can be administered through a free flowing IV line, and it may also cause extravasation. So, in the properties of individual alkylating agent, we first observe the nitrogen mustards, and the nitrogen mustards are were among the first cytotoxic drug used for cancer chemotherapy, as I have discussed earlier. They had their beginnings in the deadly mustard gas poisoning of World War One. Years later, while combing through the medical records of soldiers treated for mustard gas poisoning, researchers discovered that the toxin destroyed the leukocytes. And it occurred to them that a chemical capable of destroying blood cells might also be capable of destroying cancer cells. Their experiments using nitrogen mustard to treat lymphoma were a success, thus, modern chemotherapy was born. So the six nitrogen mustards approved for chemotherapy in US, these are cyclophosphamide, mechlorethamine, bendamustine, chlorambucil, melphalan, and ifosfamide. And we have to discuss these drugs one by one. The cyclophosphamide is a bifunctional alkylating agent, and you have known that the alkylating agent which have two reactive sites on DNA is called bifunctional. And alkylating agent means it can cause the alkylation of DNA, that is the addition of alkyl group during the synthesis of DNA at any time. And due to this, it is phase non-specific, so it is active against a broad spectrum of neoplastic disease. Indications include: number one, Hodgkin's disease, non-Hodgkin's lymphoma, multiple myeloma, solid tumors of head, neck, ovary, and breast. And of all the alkylating agents, cyclophosphamide is employed most widely. Cyclophosphamide is a product that undergoes conversion to its active form in the liver. So, for its activation, it must use the channel of liver, and this activation is required. Onset of effect is delayed, so it is not a vesicant and can be administered per oral as well as IV. Oral doses should be administered with food. Dose limiting toxicity, that is bone marrow suppression, severe nausea, vomiting, alopecia are common, and it can also cause the acute hemorrhagic cystitis, that is the blood injury, and associated bleeding can be minimized. So this hemorrhagic cystitis associated with cyclophosphamide and ifosfamide is eradicated or minimized or reduced by adequate hydration. Number one, the first activity which the physician have to be done is adequate hydration, and the second is the protective agent, which is known as MESNA, MESNA, and when the high dose cyclophosphamide is employed. This is the protective agent of the cystitis, hemorrhagic cystitis of the urinary bladder, and it is very important to treat it with, because if we have not given this with along with cyclophosphamide, MESNA is the protective agent, then we have observed the blood in the urine, and it is also causes some more complications. Beside we have treating the cancer, we are involved in treating the complication. So masna is very important during the administration of cyclophosphamide. Other adverse effects include sterility, immunosuppression, and hypersensitivity reaction. The other agent is mechlorethamine. Mechlorethamine is also a bifunctional compound. It was also the first alkylating agent employed clinically. Indication include bronchogenic carcinoma, Hodgkin's disease, leukemias, mycosis fungoides. Mechlorethamine is a powerful vesicant and can cause severe local injury. According to systematic therapy, drug can be administered IV. Caution must be exercised to avoid both extravasation and direct contact with the skin. And dose limiting toxicity is bone marrow suppression. Other toxicities include severe nausea and vomiting, alopecia, diarrhea, stomatitis, amenorrhea, and sterility. Bendamustine is a derivative of mechlormethamine and can be better tolerated. It has two indications, that is chronic lymphocytic leukemia and non-Hodgkin's lymphoma. IV administration is preferable. Dose limiting toxicity is again bone marrow suppression along with nausea, vomiting are common, and some patients experience an infusion reaction characterized by fever, hypotension, chills, rigors, and myalgias. So some kind of skin reaction are also observed at post-marketing level, including bullous exanthema and toxic epidermal necrolysis. Come towards chlorambucil. The chlorambucil is a nitrogen mustard, is generally well tolerated. Bone marrow suppression is major dose limiting toxicity, and other effects are hepatotoxicity, sterility, and rarely the pulmonary fibrosis, nausea, and vomiting are mild. It is a drug of choice for palliative therapy of chronic lymphocytic leukemia. Drugs also used for Hodgkin's, non-Hodgkin's, and multiple myeloma. Melphalan is another bifunctional agent which is well tolerated. Bone marrow suppression is the major dose limiting toxicity, and it can be used can cause secondary malignancy and is mutagenic like other alkylating agent. Melphalan is not a vesicant. It can cause severe nausea and vomiting. Administration is per and IV both, and the drug is preferred for multiple myeloma and active against also lymphoma and carcinoma of the ovary and breast. Now come towards ifosfamide. Ifosfamide is the derivative of cyclophosphamide, and it is used to treat the refractory germ cell testicular cancer and off-label use against the tumors of including Hodgkin's and non-Hodgkin's lymphoma, non-small cell and small cell lung cancer, head and neck cancer. Those limiting toxicity include the bone marrow suppression and hemorrhagic cystitis. And again, as uh, we have learned in the cyclophosphamide, the ifosfamide has a protective therapy with mesna to reduce the risk of cystitis, and by extensive hydration, that is at least 2 liters of oral or IV fluid daily. Owing to the risk of cystitis, urinalysis should be performed before each dose. If the analysis reveals microscopic hematuria, dosing should be postponed until hematuria resolves. So, additional adverse effects include nausea, vomiting, metabolic acidosis, and central nervous system toxicity, confusion, hallucination, and blood vision. Severe adverse effects are most likely in patients receiving high dose therapy and in those with renal function. The administration is IV. The other class of drug is nitrosurias, which include carmustine, lumastine, and streptozocin. The carmustine is the CCNU. It is also known as CCNU. It is the first nitrosuria to undergo extensive clinical testing and can be considered as prototype for the drug. It has the ability to cross blood-brain barrier and is also useful, especially the useful against primary and metastatic tumor of the brain. So brain tumors or brain cancers, the drug of choice for brain cancer and brain tumors is carmustine, that is the nitrosurias, because it crosses the blood-brain barrier. Other indications include Hodgkin disease, non-Hodgkin lymphomas, multiple myeloma, malignant melanoma, hepatoma, and adenocarcinoma of the stomach, colon, and rectum. The dose limiting toxicity is bone marrow suppression, leukocyte, and platelet. Nathers occurs 4 to 6 weeks after treatment. Nausea, vomiting can be severe. Injury of the liver and kidneys has been reported. High cumulative dose may cause pulmonary fibrosis. Accordingly, if pulmonary function begins to decline, glucocorticoid should be given to prevent fibrosis. And the most importantly, the glucocorticoid is used for to prevent the pulmonary fibrosis is dexamethasone IV and sometimes methylprednisolone. So, administration is topical or IV. Topical, as I have already told you, that is the CNS implant. Um, which is a biodegradable carmustine impregnated wafer, and it is implanted by a surgical removal of a brain tumor. From where the tumor has been removed, the implant has incorporated, and this technique is obviously benefited to the patient. And administration, while during the IV administration, carmustine can cause local phlebitis and extravasation injury, so it is not a vesicant. Another drug that is lumastine is very similar to carmustine, and its action and uses are very similar. Approved for brain cancer, that because it crosses the blood-brain barrier. Also, another indication approved for Hodgkin disease. Those limiting toxicity is again bone marrow suppression and nausea, vomiting, while hepatic toxicity, pulmonary fibrosis, and neurologic action also observed while the dosing is oral. In case of streptozocin, It differs significantly from other nitrosurias because the drug contain a glucose moiety that cause selective uptake by islet cells of pancreas. So this property underlies the drug's only approved indication in metastatic islet cell tumors, that is the pancreatic tumor. Major dose limiting toxicity is kidney damage, and the renal function should be monitored in all patients. Other than this, nausea and vomiting can be severe. Other toxicity include hypoglycemia, hyperglycemia, diarrhea, chills, fever, and nitrosurias. In contrast to other nitrosurias, streptozotocin cause minimal bone marrow suppression, and the administration is IV. The other alkylating agent include busulfan. Busulfan is again a bifunctional agent and approved for the use in chronic myelogenous leukemia. Dose limiting toxicity include bone marrow suppression, pulmonary infiltrates, pulmonary fibrosis, and the toxicities include nausea, vomiting, alopecia, gynecomastia, male and female sterility, skin hyperpigmentation, cataract, seizure, and liver injury. The route of administration approved for busulfan is oral and IV both. Temozolomide, the therapeutic use is anaplastic astrocytoma, and it is has a relapse after treatment with preferred agent procarbazine, and atrosuria is indicated with it. Temozolomide can also benefit patient with a recurrent glioblastoma multiforme. Both of these cancer arise from glial cells in the brain, and both eventually recur despite aggressive treatment. So, by giving the temozolomide, there is a chance of recurrence of the brain, and it can increase health related quality of life. It also, the dosages can be depend on cancer being treated. There are some difficulty in giving this drug, but the pharmacokinetics and mechanism of action uh, undergo nearly complete absorption after oral dosing, and the rate and extent of absorption depends on the food. Once in the body, temozolomide undergo rapid non-enzymatic conversion to its active form, an alkylating agent known as MTIC. As MTIC, the drug alkylate DNA and thereby causes cell death. So it can crosses the blood-brain barrier radially to reach its site of action. The elimination half-life is 1.8 hours. The adversities included the myelosuppression, including the neutropenia and thrombocytopenia. Other common adverse effects included the nausea, vomiting, and it can be treated and responded by antiemetic drugs. The most common reaction include headache, fatigue, constipation, and diarrhea. Convulsion may also occur. Patient must not open temozolomide capsules. A drug can cause local injury following inhalation or contact with the skin of mucous membrane. So it is again in the shell, and very much you may call that in the uh, preventive measures. So these all about the, it is about the alkylating agent, and we are have three compounds, two or three compounds of platinum compounds. So I have also to discuss in this with alkylating agent, that is the platinum compounds, anti-cancer drugs, cisplatin, carboplatin, and oxaliplatin, which are very similar to alkylating agent. So it should be discussed here with along with alkylating agent. It can also cause, it can produce cross linkage in DNA, and it also bifunctional alkylating agent activity, and it is also cell cycle non-specific phase. Cisplatin is available as platinol as a brand, and it can uh, primarily kill the cancer cell by forming the cross linkages between and within the strands of DNA. Drug is approved for metastatic testicular and ovarian cancer and advanced bladder cancer. So the off-label used as off-care regimes for lung cancer and head and neck cancer. Major dose-limiting toxicity include the kidney damage, that is the nephrotoxicity, and it can be minimized by extensive hydration coupled with diuretic therapy and amifostine. So cisplatin is highly hematogenic. Nausea and vomiting begin about 1 hour after dosing and can persist for several days. The other adverse effects include the important peripheral neuropathy, mild to moderate bone marrow suppression, kidney damage, and ototoxicity. The administration is IV, and it is also manifests the tinnitus and high frequency hearing loss. Another drug is carboplatin. It is very similar to cisplatin. The cell will appear to final result from cross linkages of DNA. Drug only approved for initial and palliative therapy of advanced ovarian cancer. The unlabeled use is for small cell cancer of the lung, squamous cell cancer of the head and neck, and endometrial cancer, that is the cancer of endometrium. Nausea and vomiting is occur, and along with the bone marrow suppression in the dose limiting toxicity, as also observed the nephrotoxicity, the neurotoxicity, and ototoxicity. Carboplatin is again administered by IV infusion. Anaphylactic reactions may occur, which can be managed by epinephrine, glucocorticoid, and antihistamine. And oxaliplatin is very similar to carboplatin, and it is an intra and interstand cross linkages in DNA involved in it. It is approved only for colorectal cancer and in combination with fluorouracil leucovorin is very important, and proactively and prevently measure given with fluorouracil, which we discuss later. And the regime may be used for adjuvant therapy following complete tumor reaction or in patient with advanced colorectal cancer. Investigational use include the mesothelioma, non-Hodgkin's lymphoma, and cancer of the breast, ovary, pancreas, prostate, and lung. The administration is by IV infusion, and the toxicity include the peripheral sensory neuropathy, which has developed due to by showing the symptoms of numbness or tingling in the fingers and toes around the mouth and throat. Neuropathy develop in most patients either early in treatment after several courses. And beside this neuropathy, the other toxicities include the bone marrow suppression, and other common reactions include nausea and vomiting associated with 30% of the patients. The diarrhea, the fever, the abdominal pain are also associated with it. And the infections commonly occur, at least in part of the neutropenia, because life-threatening anaphylactic reaction may develop. They are commonly used epinephrine, glucocorticoid, and antihistamine so as for the treatment. So this is about all about the alkylating agent. I hope you have understand all the topics, all the points which we discussed in this chapter. If there is any query, kindly ask in the comment section. Thank you so much, class.